Awesome. Well, I want to thank everybody for joining us. I know as many of you continue to log in, we'll kind of get started. That way we can stay on track, and then we will hopefully have some of the other panelists join us in the process. Before we get started, I want to thank our two sponsors. So both Zimmer Biomet and Stryker for sponsoring the Journal Club, and I believe, Steve, we have a short video. Wonderful. Well, thank you again for all of you who have joined, and I want to thank our panelists. As you'll see, these are some of the thought leaders and kind of world leaders in this topic of total elbow arthroplasty. I think you're going to learn a lot, as I'm looking forward to. So I think without further ado, so my colleague Chris Clifto is going to be manning the discussion. So please feel free to chime in with any questions that you have, included in the chat, and we'll get your answers to the experts as quick as possible. So
yeah, please put your questions in the Q&A. This is a lot more fun when it's more interactive, and we'll make sure to get your questions to the experts.
Fantastic. All right, I'm going to just start with the first one, and then Chris will do the next. So the first article, for those that have it, it's Dr. Sanchez-Sotelo, Dr. Mori's article on the total elbow arthroplasty in the rheumatoid population. So the really classic article on 461 primary total elbows performed over 24 years. This really serves as one of our foundations for how we understand how ultimately this prosthesis works. The average follow-up was 10 years, a range of 2 to 30. So really an astounding article. Overall, the revision rate was 11%. There's many different reasons for failure. Mechanical failure, epileptic loosening were the two most common. Bushing change infection followed. The ulnar component was almost double the humeral component with regards to loosening. And then when you look at the survivorship, and I'm sure many of you quote your patients from this article. So at 10 years, your survivorship's around 92%, 15, 83, 20%, 68%. And one of the, I think, really interesting ones is the aseptic loosening and bushing and change 20-year survivorships were both in the high 80s. Ultimately, of the surviving elbows, about 23% had bushing wear. So it really shows that this is a really important consideration. And then ultimately it talks about some of the patients that had the risk, whether it's male sex, the post-traumatics, or those with that PMMA coding, and then the post-op complications really being ulnar fractures or humerus fractures. So this is a phenomenal study, like really a landmark one, particularly in this field. Showed really excellent overall survival rates in these rheumatoid patients, but did emphasize that the ulnar component is the one that has the issues, and that polywear does happen, especially when you follow it over long term. So so Joaquin or Dr. Sanchez-Sotelo, given that you were the lead on this article, if you don't mind, can you sort of tell us what you learned when you were doing this article, and then how you're counseling from when this was published and the time period this published to now? How has that changed when you're counseling a patient with rheumatoid arthritis that is a candidate for a total elbow arthroplasty?
Thank you, Eric, and thank you, Chris, for inviting us tonight. What a great idea for all our fellows. So this paper, as you can imagine, took a lot of work. I was actually starting my time at Mayo Clinic after fellowship as a consultant, and at the beginning I wasn't very busy with my clinical practice until I had enough cases to fill my OR. So I actually looked at the records and the exercise of the cases myself. And it's important for the fellows to understand that this is a paper that captures patients from 1982 to 2006. And the reason why that's important is because patients that had RA back then, before the DMARDs were available, were polyarticular and not as active. So the current rheumatoid patient is different than the patients that were included in this study. What we wanted to do in the study is be very focused and talk only about inflammatory arthritis, and then one implant design, which is the Kunrad-Mori. And I think the message is that in those patients that had the classic polyarticular RA, the Kunrad-Mori arthroplasty worked really, really well. but there were some problems. So stem loosening became uncommon with the current Radmori for a number of features, but it still remained a problem on the ulnar side, like you said, mostly because of a change in surface treatment over time. And Dr. Ramsey, who's on the call, knows this very well. We both used this component over time, and there was a number of years where there was this so-called pre-coated component that failed much more. That is what drove ulnar failure higher. Polyethylene wear on X-rays was seen very commonly. At least 1 of every 4 patients had polyethylene wear, but revision for isolated poly wear was less common. So I think this paper is interesting because it sets the standard, but I don't think it can be translated to 2021, where rheumatoid patients that come to see us with a bad elbow typically have other joints in very good shape and are much more active. So we probably need a higher performance implant today than we needed between 1982 and 2006.
Fantastic. No, that's an awesome summary. So Dr. Ramsey, do you want to chime in? Sort of what's your experience with the maybe today's rheumatoid patients? Thoughts on the failures of the pre-coated and maybe how you can optimize the current ulnar fixation?
Thanks again, Eric, and thanks for having us. This is fabulous. So I think there are a couple of things that Joaquin pointed out that are critically important. One is the fact that this PMMA pre-coat, that was a disaster in terms of implant design and surface preparation. And one of the challenging things, there was some of these folks had what was called polyethylene wear, but when we did a retrieval study where we looked at a lot of these failed implants, and it's really hard in the face of a PMMA pre-coat where you're having basically delamination of the cement and the implant starts pistoning. You get cement disease, you get titanium debris, you get poly debris, and it's hard to kind of decide what comes first, the chicken or the egg in some of those things. That being said, there are currently the PMMA pre-coated devices off the market now, and it's not available. So the surface preparation is back to a surface preparation that is much more durable, and the performance actually in some of the studies has been quite good at this point. I think the point that Joaquin makes too, and it's a really important one in terms of what the rheumatoid population looked like in this study compared to what rheumatoids look like now. I mean, the biologic agents for rheumatoid arthritis have completely changed the patients that we see. Hello, Sean O'Driscoll. I just saw you join. It's great to see you.
Yeah, hello. My apologies. I had trouble getting in, but
me too. I freaked out right up until the last minute, but here we all are. So the rheumatoids that we see now are very rarely these mutilans, multi-joint involved rheumatoids. So they get on their biologics early. Many of their joints are spared, and if you see them, they're often a pauci-articular single joint or maybe a couple of joint involvement, which means they're much higher demand patients. And when you talk about kind of why the rheumatoid population has done so well, I mean, this is a fabulous study. I mean, 24-year follow-up is remarkable. In this country, it's a remarkable follow-up. And the reason these people did so well is they were extraordinarily low demand. They just wanted pain relief. They didn't, functionally, their elbows didn't always perform great. They were sometimes stiff, but they didn't hurt and they didn't do much with them. So these people did pretty well. I think to your second question, and I'll kind of make this quick, and what do we do technically differently now? I think the most important thing starts at implant choice, and I think now most of the major implants on the market are all designed very similarly. There may be minor variations, but they all are implants that have a lot of polyethylene, a lot more than they used to. One of the knocks on the Coonrad implant was the bushings were pretty thin. And bushing wear, while we talk about bushing wear and poly disease, bushing wear is an expected part of any joint replacement. And if you have metal articulating on poly, you will get wear debris. And the question is, how quickly does that become a problem? And the less poly you have, the quicker the problem surfaces. So most of the newer implants now have much thicker poly. They're different vitamin E, impregnated polyethylene, highly cross-linked polys. how you prepare the ulna. I think Ken Faber did a study years ago now that looked at, like when we first started putting these implants in, and even in some of the experience I'm sure that Joaquin had looking at these, we would just squirt some cement down the canal and dump this implant in. We didn't really prepare the canal well. We didn't use cement restrictors. And I think those things have proven to be very important and are an important element in my practice. It's a little harder in the ulna because you definitely have some geometrical constraints in putting cement restrictors in, but they're really important. You lavage and dry the canal, pressurize your cement. And so from a preparation standpoint, those clearly improve cement technique, which improves fixation. I think putting it in well is a really important thing. You can't malrotate your ulnar component. Putting it in too proud or too deep can run into issues with impingement. Sean's talked about impingement of the coronoid against the flange of the implant and flexion, and how that can lead to a kind of a longitudinal pistoning of the implant. So beyond just actually putting it in better, recognizing what the mechanisms of failure are, a malrotated component leads to asymmetric polywear, a component that's either too deep and we now resect a little bit of the coronoid to prevent impingement and flexion that can lead to pisting of the implant. So those are all some things we do differently now.
Phenomenal. Dr. Driscoll, do you want to sort of expand upon that? Some maybe either implant or technical factors that have improved our ability of either ulnar or humeral fixation, and kind of what you see as going forward in the future with regards to this evolution that we've seen.
Yeah, well, thanks very much. Matt did a superb job of summarizing it all, really. And there are a few additional things that I think are relevant. Surgical approach now is something that is of real real interest to us because of the potential impact that surgical approach has on one's ability to actually execute and accomplish those goals. And so, for example, if you have a triceps on approach, depending on the implant that you're using, if you're using an implant including a radial head component, I think in most people's hands, it's quite a bit harder to be sure that you've got implant technical execution to be at the same level that you would with some form of a triceps approach, like currently we're using the diamond pop-up, which gives you great exposure, and we hope and have reason to suspect that long-term we'll have a lot better results with the triceps healing. Other aspects have to do with anticipating revision. So some of us have moved towards using thin cement mantles in which we go for a press fit for the stem, and the cement is just a grouting. So there's not as much cement in the canal. And then secondly, trying to limit the cement past the tips of the stem. So I actually impact bone at the endpoints of the trials so that when I put the cement in there, the cement really doesn't go beyond the tip of the prosthesis, and then I drive the prosthesis into that little bone plug. So if you have to revise, you don't have to go after a cement plug, and that makes a huge difference for revision. Now, will it be just as satisfactory for longevity in terms of fixation of the stem? That remains to be proven, whether that's the case or not. There'd be some theoretical reason that it's not, but our sense is that's potentially a real advantage as well.
Wonderful. And then maybe one last question. So Dr. Mori or Mark, so when you're, let's transition to non-rheumatoid or a little bit more active patients that you're considering this prosthesis for. Can you talk to us about like your considerations of these patients, either any technical changes you might do, or at least how you sort of coach them through the need for this total level?
Sure. So with a younger patient, higher demand patient, right now I'm using the Latitude implant because of the bushings. The bushings, and at least when I looked this up, over the last 10 years had almost nowhere at 10 years. So for a younger patient, that's my implant of choice. I'll start there. But counseling them has always been, for me, depending on their demands, activity level, etc., has always been a conversation, usually between that and interposition arthroplasty. And I realize that I'm the minority in interposition arthroplasty, but that's still a conversation I have with patients who are high demand. And the patients are higher demand. Our inflection point in terms of the DMARDs that we've been talking about happened in about 2002. And that's where the post-traumatic or the sequelas of trauma overtook the rheumatoid population. And now it is totally flipped on its head. Now it's all for post-traumatic or the sequelas of trauma, and that's a different population. It's a much harder population in terms of the demands on the implant. And a lot of that has, I think, to do with deformity. So if it's a sequela of trauma, not just an acute trauma, they have a lot of deformity. So the soft tissue balancing is more difficult. So that may affect how you approach the elbow in terms of getting soft tissue balance correct. And I know that we haven't talked a lot about soft tissue balancing for the elbow, but it's important. The reason I think it's important is because it will offload the stresses that the implant interfaces see. So your cement bone interface, the implant to cement interface will not see the stresses if you have good balance. A severely deformed elbow with a lot of contracture formation, off-axis lines of pull, that's gonna transmit those forces to the implant interfaces, and I think that's something that we've learned with these harder cases. So not only is it the implant, but it's how you approach your balancing in the overall procedure.
And if I can make another comment, Eric, I think something that
Yeah.
Dr. Ramsey mentioned that is very important is that the quality of implantation is essential for the survivorship of the implant. And since we have a fellows night to night, many fellows may not have a lot of exposure to primary arthroplasty of the elbow. In our practice, we do many more revisions actually. So I think this is an operation that as a fellow, when you transition into your practice, if you want to perform, it is really worth it to go to a cadaver training session by a company, or maybe visit one of the experts that are part of our society, because just watching it for a couple of times in the hands of an expert will really change your perspective. Whereas if you just read a PDF of a technique and try to do it, you're not going to be the same. So I think there's an opportunity for real training through ASCS in primary elbow arthroplasty.
Oh, absolutely. Thank you. Anything else before we move on to the next question from any of our experts? Wonderful. Clifton, do you want to take us away at the posterior condylar?
Absolutely. And I echo that completely. In my first year in practice, I came up actually to Mayo to work with Dr. Driscoll, Dr. Moore, and Joaquin about to teach the teachers. And I learned so much about my elbow arthroplasty experience from them. So, okay. So the next study, I'm going to go quick through this because the study is great, but the discussion is going to be what I think is going to be the most fruitful. So it's called Landmarks for Rotational Alignment of the Humeral Head Component During Elbow Arthroplasty. This was a great study highlighting the difficulty of analyzing the rotational orientation of the humeral component during elbow arthroplasty due to bone loss. The goal of the study was to assess whether the flat posterior humeral cortex proximal to the olecranon fossa was a reliable landmark to orient the humeral component, which can be really challenging when you're dealing with trauma and if the condyles aren't there. So they used 50 cadaveric elbows that all had CT scans. They looked at flexion extension axis, which was determined by a sphere fitting to the capitellar surface and the circle fitting to the narrowest portion of the trochlea. The posterior humeral cortical line was drawn off the flat posterior humeral cortex proximal to the olecranon fossa. The transepicondylar axis was determined by a line between the prominent points of the epicondyles. They looked at angles between the PCL and the FEA and the TEA axis, and they were all calculated. The posterior humeral cortex was externally rotated by a mean of 14 degrees relative to the FEA, and the TA was externally rotated by a mean of 2.8 degrees relative to the flexion extension axis. So this study concluded that the posterior humeral cortex is a reproducible landmark that is externally rotated with respect to flexion extension axis of the distal humerus. And they recommend that all surgeons internally rotate the humeral component when using the posterior humeral cortex line as a reference. So first question, maybe to Dr. Mori, how do you reference the rotation of the humeral component when you're implanting the humeral component, especially when there's bone loss of the condyles?
It's a great question. And if you have the condyles are completely off and you're beyond the olecranon fossa, then the posterior humerus can be used as a reference point. But I typically use the apex of the anterior part of the humerus for my rotation. And then something that Graham King taught me was, if you're really struggling and you really are struggling with the rotation, just put the arm at the side. And if the hand reaches to the mouth in flexion, then your rotation can't be that far off. So those two little tricks, I think, are important. Can I share my screen?
I don't think so. Steve, is he able to share a screen? I don't.
Looks like I can.
Oh, perfect.
Can you see it?
Yeah.
This is a journal club first.
Yes.
Well, I just want to so the apex of the humerus is it's a triangular shaped bone, and so that can be used reliably. So if you're missing the epicondyles on one side or another, you can use the apex of the humerus to help with your rotation, and then your secondary check is hand to the mouth. But if you are proximal to that, the posterior part, and you can see it here, the posterior part of the lateral side of the lateral condyle is more prominent posteriorly than the medial side. And so that's where you can get your rotation off. And that's the study by George and Graham. So I'll stop sharing, but that's how I do it.
That's awesome. Fantastic, Mark. I love that. So I guess maybe transition. So, Dr. Ramsey, you had mentioned getting the ulnar component rotation is critical. Can you maybe talk to in both the primary or the revision setting, some of the tips that similar to what Mark shared about how you get the humerus or the ulnar, both rotations correct, how you can sort of check intraoperatively, how you sort of optimize that for both revision and primary?
Yeah, so I think Mark has talked about the humerus. On the ulnar side, without bone loss, I use two things. I use the posterior flat of the olecranon as a guide, and you want to be perpendicular to that. And then as another check, and I routinely don't take the radial head out until I've prepared my ulnar component, because you can use, if you draw a line through the center of your greater sigmoid notch, so the center of where your implant should be, through the center of your radial head, that should be a rotational axis that matches the posterior flat. And then so I will figure out my rotation of the ulna before I take the radial head out. Sometimes it's very tempting, particularly what Sean said with a triceps on approach, to see that relationship. And I would tell you too that, and I couldn't agree more with what Sean said, the biggest reason I think in young surgeons why they don't get these components in right is they don't get the best look they can get of the joint. And while we talk about certain of these triceps sparing techniques, or some of these different triceps technique like the diamond pop-up and other things like that, I mean, what Sean's really done is to try to develop a technique where you can reproducibly not sacrifice the triceps, meaning you can reproducibly get the exposure you need, but also repair the triceps and have it heal. Because I can tell you that you struggle with the triceps on all the time to get your rotation right. So to me, if you're starting out, and I'm not a big fan of a triceps, truly like a Brian Morey approach anymore, just because I think healing is an issue, that if it's really a problem, you're better off taking doing a triceps reflecting approach or a diamond pop-up or any of these alternate approaches where you actually do more to preserve the triceps attachment and get your implant in right. It doesn't do you any good to keep their triceps strong and have their elbow fail, a year into a total elbow because you've malrotated the components. So on the ulnar side, those are my two guides. When you're missing the proximal ulna, it's a little more difficult. I still reference the radial neck at that point to try to get a better assessment of rotation, same way I do when I have the radial head intact.
So we got a question from the audience from Jacob Triplet. So does having the center of the anterior flange centered on the anterior cortical prominence of the humerus ensure appropriate rotation of the humerus per Dr. Morey's comments? And maybe Dr. O'Driscoll and Joaquin could each give their answer for that. We'd love to hear it.
Go ahead, Joaquin, if you'd like.
So I think the question by Jacob is if having the articulation of the implant in line with the anterior cortex guarantees the rotation. Is that the question?
Correct, yes.
No, I'm not so sure about that. I think that you can still get mal rotated even if you have your joint axis in line with the anterior cortex. I think what Jacob may be thinking about is that in the Kunrad-Mori, the design was such so that the axis of flexurization was more anterior. Maybe that's what he's talking about. That really changes your rotational alignment. Sean, any comments?
Yeah, I think I'm on. Yeah, I think what oh, here, let me get rid of that virtual because you can't see a piece of paper. I think maybe what you're wondering about, Jacob, is if your flange is sitting on this anterior prominence as opposed to your flange being over here somewhere, that's for rotation. Is that what you're asking? I guess.
Yeah, I think
let's assume that is what you're asking. If that is what you're asking, then that's a pretty good landmark. That's what Mark was saying, that he uses the anterior cortex, because when you're missing some distal humerus and you don't have the condyles there, let alone the epicondyles, it's not very flat as you get a little further up on the back of the humerus. So you can lose the flat spot you're trying to then internally rotate from, in order to get your flexion extension axis. But that anterior prominence, it rounds off as well, but it does still stay as a prominence there. And when there's really no flat spot on the back of the humerus at all, that's what I use. And then I do just what Mark said, which I just make sure with the trial in that with no stress at all either way, that the hand heads right for the mouth when you flex the shoulder and then flex the elbow. Joaquin, is that similar?
If that was a question, I would agree. The flange can be useful. The other comment that I was going to make is that one value of ulnar clubs is to understand how can you translate a paper into your practice. And it's important to realize that this is a wonderful paper, but what they did is on CT scan, getting observers to see if they identify these different landmarks, how off the line was of the transepicondyle axis. No one has checked how good we are as surgeons identifying that plane. So it's a leap of faith to translate what you can measure on a CT scan to what you can do in the operating room, just for clarity. So that's something important to consider. This was a CT-based study, which is wonderful, very, very well done. And I always try to get my component on some internal rotation in reference to the posterior wall, but I don't know how good I am at identifying that posterior wall.
Yeah. And if I could add one, sorry.
Right. I mean, if it's a post-traumatic and there's a lot of deformity there to begin with, and those landmarks are off. So it's not a CT scan. We're talking about abnormals.
Yeah. If I could add one more comment, I'd like to emphasize what Matt said about how important ulnar rotation is. Ulnar component rotation is, I think, exceedingly important, because as soon as it's mal-rotated, then in one position or other, the elbow wants to subluxate, or if it's not permitted to, it's really loading the polyethylene. And so ulnar component rotation is critically important. And just try a cadaver sometime and intentionally mal-rotate the ulnar component and see what happens. That's when it'll really stand out. And then the second thing is that I must say I've yet to be convinced after all these years that humeral rotation is as important as we think it should be. Only if you're missing the distal humerus. If you're not missing the distal humerus, then you need to get it right. But let's say you're talking about a situation with no condyles, and so you're using this posterior humeral surface. I have a general sense from a theoretical and a practical perspective that it might not be as important, despite I think many of my colleagues think it probably is. I'm not sure if anyone has changed and thinks that maybe it isn't as important. I don't want to get bogged down in why I think it isn't, but do you guys think? I mean, Matt, Joaquin, Mark, do you think if you're missing the humerus?
Similar to soft tissue balancing for me, Sean. So if the humeral rotation is off axis, and so the motors that are pulling it are now going to pull it off axis, then the forces are going to be transmitted to the implant interfaces. So for me, it's like it's akin to soft tissue balancing. And
so can I ask you a question of you, Mark? Because I'm fascinated by this, like you are, and this is particularly relevant in deformity. So post-traumatic deformity, particularly the dysfunctionally unstable elbow that's contracted.
Mhm.
So we spend all this time putting our implants in. Tell me about how you, because I'm not convinced that we can always balance our soft tissues. And I only say this because I have a colleague who, when he does these operations, particularly in the face of trauma, will kind of put the implant in linked and then just kind of flex and extend the elbow and let it kind of find its place within the soft tissue envelope. Because I personally think that on some of these really contracted elbows where you're really trying to align the forearm now back down underneath through the implant, that, let's just say, the typical is the forearm goes medially and the humerus sticks out distally laterally. So you're really contracted on the medial side and you're attenuated laterally. Like, what do you release and how much do you release it to get the deformity, soft tissue deformity, corrected? I think we're actually more limited to some degree than we think. And I think that as you start repairing the soft tissues, I mean, maybe you don't. That's, I guess, the question is, like, what won't you do because you're afraid that if you repair something that you release, you're just going to actually reacquire or reinstitute the deformity that you're trying to correct from a soft tissue standpoint?
Yeah, that's an awesome question, and I think you're right. It's not normal, but it's their new normal. So I think the idea of putting the implant in and just seeing where it lies is actually a really good one, because that's now the soft tissue balance that you would hope.
Right.
The other way to tackle that, and you can do this maybe easier if they have a lot of bone loss, is if you're doing a triceps on approach, you're releasing the entire distal humerus.
Yeah.
So that soft tissue envelope becomes completely enucleated, in which case then the balance becomes a little bit easier. And if you don't have epicondyles to reattach the soft tissues to, you're reapproximating it to, say, the margins of the triceps. And that provides a soft tissue envelope that is going to heal to the humerus in some way, or scar to the humerus in some way. And if you are taking the elbow through the range of motion, then you can see where you're putting it back to where it is going to be, I guess, not tight in any one plane. Similar to what your colleague is doing when they're just putting it in and flexing and extending it. So I think two different ways of tackling it.
I mean, I think what we're all saying here is how you put this in and what envelope you put it into is really important.
Yeah.
And if you asymmetrically load your implant because you've either malrotated it or you haven't dealt with the tissues, you're essentially biasing it towards a constrained implant. And as everybody's saying, is that can lead to accelerated wear and loosening. And if you look at the results, the nice thing about the Mayo Group is they have divided the elbow up by pathology and reported it pathologically, which is unique. A lot of these articles are written, have hundreds of different diagnoses in one paper. They tend to kind of divide it up into post-traumatic, rheumatoid, so you can really understand how these implants perform in the pathology that you're going to want. So it really helps, and it helps direct the discussion with the patient. And the post-traumatic results are not great comparatively. I mean, it is a challenging group. And I think, Mark, what you said before is absolutely right. You throw deformity into the mix, and that's like a match to a gallon of gas. I mean, it's really a tough population, and they wear things out. And I understand. I mean, I am not as enthusiastic about interposition as you are, but I understand the reason you are, because we don't really have answers for a 40-year-old with post-traumatic deformity. I mean, we all shudder at the thought of doing total elbow replacement in that patient. Yeah. Not that we don't do it, but we worry.
Yeah, right. Right. I mean, sometimes it's the only option left. And if somebody is, grossly unstable, then I'm not considering an interposition either. And that patient's getting a total elbow because that's what they need. I mean, it is a salvage of a salvage. But there are a couple of other things too. You talked about insertion of the ulnar component. It's like a fracture. You get the length, alignment, and rotation right. So, when you are inserting the ulnar component, particularly because of the ulnar bow. The ulnar component has a tendency to want to rotate. So it wants to spin within the ulnar canal, and that's even harder when you have a triceps on. And then the other way you can get it wrong is you can insert it too deep, particularly in a rheumatoid who's got a really expanded olecranon fossa. Then you can insert it too deep, and now they can impinge in front, or they can impinge in back. And those are a couple of the mechanisms where you're going to have ulnar pull out, or you're going to have ulnar malrotation and then early loosening, or you're going to have impingement in the back and you're going to fracture an olecranon, because again, it's the deformity, right? Or you're going to stress the interfaces again. So all of those things are I think important when you're talking about getting the balance right.
Amazing. That was incredible. Thank you all for really prolonging that discussion. I'm going to quickly move on to our second to last one, and this kind of fits a bit with some of the conversation now. It's migrated to some of the more challenging settings or the revision settings. So we're going to talk about the APC article. So Mark and Joaquin's article on using an allograft prosthetic composite in the revision setting for a total elbow. Or a failed total elbow. So it's a single institution's experience with this catastrophic TEA failures with bone loss. There's 25 revision total elbows that were performed with these APCs. The humerus was in 6, the ulna was in 18, and then both were in 1. There was a variety of different etiologies, most commonly aseptic loosening plus fractures. Infections was another one. 5 of the 7 infections were staged. Ultimately, patients did well. There was 3 different types of reconstruction strategies they brought up: intussusception, strut, and the type 3 side to side. They had a very high rate of allograft incorporation, and but they did have a reasonable rate of major complications, as you can imagine, in this very complex setting. 32% major complications, with infection and fracture being the main one. Ultimately, 5 underwent revision. 1 of them was revised to another APC, another one. The other 4 were resection arthroplasties, and then ultimately 84% had a functional elbow at the last follow-up. That's probably the most incredible thing about this. So ultimately, phenomenal article, phenomenal sort of surgical innovation, and showing us a real salvage operation in a very difficult patient population. The other cool thing that was kind of hidden in the details is they showed the decrease in surgical time from basically like half the time from a previously published article, and then subsequently they've even gone on to publish about the using a triceps ulnar component or ulnar APC that has triceps on. So I mean, really interesting and thought-provoking study, and sort of the start of I'm sure many more similar ones. So Mark, maybe you can lead us off, given you helped to lead this article. So what are your current indications when you're dealing with bone loss for an APC versus some of these other procedures, and how have they evolved since this study, and then since some of your more recent ones, including the ulnar allograft with the triceps on?
Sure. So I think it really falls into the 2 categories. So if you've got a lot of missing humerus, how much is too much to miss, and then when would you go with an APC? And for me, I would like to have circumferential containment of the plasma, or the flange has to reach native bone, and you can accept up to 2 centimeters of shortening, and the flange can reach. But you also need to think about the longevity of the implant in terms of stability, and that is primary stability with the cement, and then getting the bone graft to heal behind the flange. And so for me, that distance or that amount is about 8 centimeters. So I'm going to share my screen again, okay? So I just think it helps to just, a picture's worth 1,000 words.
Yeah, I appreciate it.
I'm not good at talking. So this is a Coonrad Mori implant. The flange, and this one is a little bit, they're about the same in this one versus a latitude or a DJO, although the DJO is meant to go directly in front of the of the cortex without a bone graft. But here you can see a short flange in this first one, and then a long flange, and you can see how much bone is missing between these, and it is essentially about 8 centimeters before you can no longer engage the flange at all. And I would say 6 centimeters is sort of a, you want to be able to have the bone graft heal behind it, and that is with 2 centimeters of shortening already. So for me, that's kind of my cutoff, anywhere between 6 and 8 centimeters for the humeral side, and that will allow me to cement the plasma coat, or the majority of the plasma coat, and get flange engagement. So the humeral side, those are the two things that I look at. On the ulnar side, for me, it is there an olecranon? So is the implant covered? So, or do they have an extensor mechanism loss? So if the implant is uncovered, we know that those have a tendency to erode through the soft tissues, and that's also not an ideal situation. So if the implant is uncovered, or the ulnar axis is uncovered, then I will use a proximal a graft of some kind, and that's not always circumferential. Sometimes it's just sort of a kind of a Cupid or a nesting doll kind of approach. I've got a picture here somewhere, but I'm going to stop my sharing. And then you need motors, right? You need an extensor mechanism. Then I'm using an allograft prosthetic composite for those patients as well. So those are my my indications for the two, and why I would use one.
Wonderful. Joaquin, can you talk to us about, I learned this technique both in shoulder and elbow from you, or during our time together. And can you talk to us and maybe even teach me from what I've missed from not having to work with you for a while? What is your current technique? Some technical tips you have with regards to considering this on both the humerus and the ulnar side, and how your technique has evolved.
So I think for me, over the last 10 years or so, the two main changes that I have incorporated in my practice for APC reconstruction are the use of a plate and the use of a graft with soft tissues. So when Mark Morley published this paper, of course, these patients have been followed longer over time. And Mark and I have discussed this, that some patients that in the study were still successes, 3 years later became failures. And especially on the humeral side, because of the torque of gravity, I think having a plate to control rotational stability is very important. And to be honest, I think Sean O'Driscoll has used plates forever. I was using more wires at the beginning of my training, and Sean used to tell me, well, you use a plate. And everyone is like, you cannot get screws around the implants, and in reality you can. So I use plates routinely for my fixation. That's number one. Number two, to Mark's point, when you're missing proximal ulna, by definition, you're also missing the triceps. And what I used to do when I came out of practice is to use maybe a proximal ulna, sometimes a proximal fibula because it's smaller, and then an Achilles allograft. And obviously, allograft tendon to allograft bone doesn't heal, so that was a disaster. So then I started thinking about, what about ordering a proximal ulna with triceps? And then we move on into doing that, and that has been a game changer. On the humeral side, though, I must admit that I still have more failures than I would wish. So I think there is room for opportunity to design a true custom-made prosthesis for the complex revision humeral side. Whereas on the ulnar side, we need the triceps. So I think we'll be sticking to APC. So I believe that in the next 10 years, we'll have a successful 2 more prostheses like for the humeral side. We will still need an allograft for the ulna with triceps.
Amazing. Dr. Driscoll, can you expand upon this? Your thoughts on some of the comments that Joaquin made about maybe the implant innovation in some of these more complex revision settings, or maybe even some technical innovations that you see coming our way or that you currently are using?
Yeah, well, as usual, Joaquin just said it perfectly. I don't really have to add anything. I'm not sure I would be adding, really. I certainly agree with everything that he has said. And yes, I've always used plates and thought we should with APCs. You can my experience, always get screws around the implant on humeral, the ulnar side. I don't mean I've done it 1,000 times to be able to say that, but I've never had a situation where I wasn't able to do that. A couple of things that I would add to it would be perhaps that recently we've realized that with some of these ulnar APCs that there's a risk of fatigue fracture. And as we had these, and the three of us sit, in the same row there, so we're looking at the cases together and in clinic, and initially it seemed, well, it's fracturing at a screw site. Well, maybe we shouldn't, we have to support it a little bit better. Maybe we should use wires instead of screws. And then it fractures at the wire. And then, well, maybe we should use a plate, and then, well, it can fracture at the end of the plate. I think it was Graham King recently, said that he thinks that we should span the entire allograft right down onto the native bone with a long plate. And then that made a great deal of sense to me. And I hadn't done that, but that's what I would do with the next one is I would put a long ulnar plate, a long olecranon plate, on it, just span it completely. Whether or not that'll prevent that problem, I don't know. I have come to the same conclusion about the humeral APCs. I've had a number of these that I thought technically they were the kind of things you would just want to show at a conference or put it in a publication. They were just so perfect that failed. And it's been really disappointing, really disappointing. Not even sure what I could do better, you might say, to have them not fail. So my sense is that there will be room for a tumor-like prosthesis on the humeral side. And hopefully we can continue on the ulnar side. I would mention that if you really have no ulnar to work with whatsoever, I have on one occasion put the ulnar component into the radius. I've seen that patient at, I think he's now about 20 years follow-up, I think. It's one, you can't learn much from an N of one, but you can sometimes get some insight from an N of one. I would just add maybe one other thing about revision settings that I think has been a huge change for me. And that has to do nothing about the implant, but with approaches. So raising no skin flaps. Don't go after the ulnar nerve if the ulnar nerve is not going to be in your surgical field, which you can determine preoperatively on a combination of CT scan in some cases, but ultrasound tracing. So I routinely trace the nerve with an ultrasound pre-op with it. Well, I don't do it. A partner of ours who's superb at it does it. And then I decide, is it in the field or it's not? If it's not in the field, I don't go after the nerve whatsoever. And that's a big change. Dr. Morey Sr. wrote at one time that in all revisions, the ulnar nerve must be explored in every case. And so that's a huge change for us to not, because it means we don't have to raise skin flaps, greatly reduce the risk of hematoma, wound healing problems, and I think probably infection. So minimal skin flaps, go straight in through a paraolecranon and right into the deep space.
Wonderful. And real quick, Dr. Ramsey, can you add maybe a couple more of your technical pearls in the revision setting, especially some of these complex, maybe not necessarily with APC, but just kind of in general?
Well, yeah. So we do have, by the way, a humeral implant that deals with some of these bone loss issues. There are systems on the market that link to existing elbow replacements that are segmental, where you have a flange that can attach to native bone proximally. So you get the flange engagement and then body below it to make up for your deficiency. So, and I don't use a lot of them because they're really expensive, but it's an option and it does exist. I think by far for me, the big, and I agree completely with what everybody has said about the humeral side, which is why to some degree I've tended to get away from APCs on the humeral side as well. I think a far bigger problem, and my biggest issue with bone loss, and the Mayo team mentions this in their discussion of their paper, is that in the face of previous infection, sticking a big chunk of dead bone in the elbow scares the crap out of me. Yeah. And the problem is this is not living bone. Like you do not, I mean, if you know anything about allograft biology, at best you get surface kind of remodeling of this graft. You do not get complete depth replacement with native bone. It's dead bone on the inside and maybe a little coating of host bone on the outside at best. And that's to Sean's point. The reason you span the whole graft is because it's not living. It's a big chunk of dead tissue. So, you know, a number of the failures in their group, and I don't think it was a majority, I think it was a minority, but it's still a significant number, are in previously infected patients. And so my biggest challenge, honestly, in terms of this whole bone loss discussion is what do you do with bone loss on the ulnar side, particularly in the face of infection? It's a real problem that I don't know how to solve that problem, because I've had, and we're looking up our results right now because my experience in the previously infected elbow has just been absolutely dismal. And I don't know that an implant's the answer for what the reasons that Joaquin said. You can't fix soft tissue to an implant for the most part. It just doesn't stick. So I don't know that I have. So the technical pearls are try not to get into a situation where you have bone loss and then you don't have to deal with it. I think it is I mean, and this is a challenge in orthopedics in general. I think reconstituting bone when you've lost bone is a really, really tough problem. And I tend to like a large segmental piece. And depending on, the article kind of talks about the different modes of failure and the different patterns of failure and how to reconstruct those failures. For me, I mean, most of the ones that I see, either you're missing the entirety of bone at some point because you've fractured maybe at the tip of the ulnar implant or more proximally, or you have the whole anterior shelf of bone up to the coronoid is maintained and you've lost everything on the dorsal side. And in those situations, I try to implant into a whole ulna with triceps attached, again, for the reasons Joaquin said. And I don't use a ton of I take a little stump. You cannot I've had the very unfortunate circumstance of going back in on one of these triceps reconstructions with Achilles and calcaneus, where you kind of keep the whole aponeurotic expansion of the triceps, and then you go back and you look at that thing about 4 weeks later, and it's just a big snot ball of necrotic tissue. So I use a very short segment of the Achilles, the very thickened portion of the Achilles, and kind of pulver taft weave it up through whatever they have. But Joaquin's point is correct. You will not get any soft tissue to heal the dead bone, so you have to keep it on the allograft. And for me, the bigger the bone that you put in, meaning the more structural it is, it has to be one big piece as opposed to kind of little matchsticks stuck together kind of thing. So that's pretty much all I got on that. I just think it's a huge problem, and I don't know how to solve the infection bone loss, previously infected bone loss problem yet. I'm working on it. And by the way, the three of you guys in clinic are all together looking at crappy elbows all day long. You guys, what do you got? Are you guys getting like electric shock therapy for depression or something? I mean, listen, I suffer in silence by myself. I can't imagine sharing my misery with two of my colleagues. It would be awful. Goodness gracious. You can't. That has to be a miserable experience.
It's like Eminem every day.
Swear to God. My God.
A cord of 3 strands is not easily broken.
Is that it? Yeah, misery loves company, right? I get it.
Something like that, yeah.
All right. Well, so maybe on that note, we'll go on to the next article. Oh, by the way, Matt Ramsey, amazing elbow surgeon, maybe even better golfer. So little known fact.
That is so ridiculous. That's not true.
All right.
But thank you.
I've played with you. Modest also. Okay, so next one is elbow hemiarthroplasty using a triceps on approach for the management of acute distal humerus fractures. So this was a great multi-center study of patients treated with an elbow hemiarthroplasty using a triceps on approach for acute distal humerus fractures. They had 16 patients. Mean follow-up was 35 months. All fractures were deemed to be unreconstructible. All patients had CT scans and patient factors were accounted for prior to decision-making. The majority of fractures were type C fractures with a coronal shear component. Mean time to surgery was 13 days. This gets a little technical, but surgery was performed through a posterior approach. 11 of the patients had triceps muscles that were in size between the lateral 1/3 and the medial 2/3 of the triceps from proximal to distal. And 7 patients had a triceps in size at the junction of the medial 1/4 and lateral 3/4 from proximal to distal aspects of the triceps. Regardless of the approach used, a second window was created along the opposite side of triceps to access the condyle. Size of the implant was judged by referencing against the patient's olecranon and radial head. Height was judged by referencing against the patient's native olecranon fossa, and second by approximating the fracture condyles with a trial stem. The condyles were fixed with a combination of suture bone tunnels and tension bands. All patients had good to excellent function. Mean flexion was 116 degrees, and mean flexion contracture was 15 degrees. There were no instances of triceps failure. One patient had a complication of an asymptomatic non-union of the medial epicondyle. 63% had radiolucent lines, which were asymptomatic. Radial head wear was present in 3 patients, and ulnar wear was present in 10. They conclude that elbow hemiarthroplasty using a triceps on approach is a reliable technique for the management of the reconstructible distal humerus fracture. So maybe for the great ball striker, Matt Ramsey, how often are you performing hemiarthroplasties? And this was a little bit before my time. I don't know if Eric has seen any hemis done, but what is the indication for doing them now?
Well, I think the first thing to know is that there is no implant on the market available in the US that allows us to do this in an anatomic way. So the 2 implants that have been traditionally used for this was the Questar Sorby implant, which was a Wright Medical product, and that was pulled off the market voluntarily by them, but got into a little beef with the FDA that they were selling a lot of distal humerus components, but no ulnar components in their total elbow, which meant that we were all using it for hemiarthroplasty. And the other was with the Latitude implant, which the implant is still obviously on the market and doing beautifully, but they had an anatomic spool instead of the total elbow spool that was available, and it still is available everywhere in the world except for our country. So it's really hard to do hemiarthroplasty in an anatomic way in this country currently. There are things you can do it. You can use the total elbow spool from the Latitude, but it does change the geometry of the joint a little bit, at least in my experience. So most of the results, or most of the articles, or at least anything that's being done in this country now, I mean, I think when these things were becoming extinct, I think Mayo bought every Wright Medical implant available in the universe.
No,
Rick Papandrea did.
Rick did. All right. Well, good for Rick. You know, they aren't available now. So that creates some issues for all of us. I don't know how the other guys are dealing with it. I mean, you know, we can't get this. I tried for a while to petition the FDA for a compassionate use exemption for the anatomic spool, and they just flatly refused it. And there's no predicate device to use this as a 510K submission. So it has to be an IDE, and there isn't a implant company on the market that's going to spend $2 million or so on an IDE for a market that's maybe $500,000 a year. It just won't happen. So, but these are used in folks who have unreconstructible articular distal humerus fractures, and you can certainly include, with some experience, the ones that involve the condyles, as long as they're reconstructible. I mean, what you need to have is intact ligaments or reconstructible ligaments. And I don't mean soft tissue reconstructible ligaments. I mean ligaments that are attached to bone that you can reconstruct to native bone. And it worked, man, for acute traumatic injuries. It was actually a very good operation. I did several of these many, many years ago. And I've really only, for trauma, I've only converted one. I think, you know, Scott Steinman's reported on his experience with some of the post-traumatic patients that might have some ulnar-sided articular injury, and they're not quite as reproducible or predictable, but for the acute trauma, they work beautifully, quite frankly. And a triceps on approach, I'm not so sure I would use a triceps on approach. I'd probably use Sean's, the diamond pop-up for that would be a really nice approach that you could do for that. But yeah, for me, it's the acute traumatic patient is with an unreconstructible articular injury is really the stereotype or prototypical patient.
Amazing. So Joaquin, do you want to talk about, you know, you publish on using total elbows for distal humerus fractures. Do you want to talk about sort of that consideration? When do you think that the total elbow for distal humerus fracture sort of makes sense versus trying to fix it, and how you kind of come to that decision?
Yeah, the big benefit of doing a total elbow for a distal humerus fracture, like Dr. Brasi was talking about, is that you can do it truly through a triceps on approach, because by removing the fragments, you have enough working space to instrument the canals and place the implants. So in my practice, for a patient that is over 70 or 75, especially female, with a destroyed elbow, that is the operation of choice. And when we look at the long-term data, as you can imagine, by 10 years, 50% of the patients that were in your study are deceased, just because you're selecting people that are really old, so they just die of other reasons. And of the surviving ones, about 80% still do well. But that's very different in a younger male patient. So the main risk factors for failure are male gender and activity level. So I think in a patient that is between 45 and 70 with a destroyed distal humerus where you cannot fix it, I would love to have a hemiarthroplasty, but like Matt said, it's not possible, but I'd love to do it.
Sorry, Dr. Driscoll or Dr. Mori, anything that you want to sort of add when you're either considering doing a either total elbow or if a hemi was available, and any maybe technical pearls when you're doing this?
Go ahead, Sean.
Okay. Well, yeah, it is unfortunate that the Hemi's not available. Now, conflict of interest, I'm a designer of that. And I've used the Sorby as well. But having said that, it is unfortunate. It's available everywhere else except in the USA, and there certainly is a role for it. There are numerous advantages. Obviously, you don't have an ulnar implant or a radial head implant to be concerned about. You don't have polyethylene to be concerned about. There are some and it's convertible. There are some disadvantages. It's not just simply a better way to go. In my experience, when they were available, like when Matt was saying, when they were available to us, I found that patients had a little harder time rehabbing, and they didn't get quite the kind of motion that they've got in this study here. I think it might have to do with approach, by the way, but they didn't get as good motion back as they did with a total elbow. And I think it has to do with the fact that they were relying on fractures to heal while they were rehabbing in order to have stability. Very different from a total elbow. You're not relying on the fractures to heal. You've got a linked implant in there. And the other has to do with the fact that we tried to not only preserve as much soft tissue as possible, we repaired any soft tissue that we divided for stability reasons. Now, I think it's been learned really, but it's being learned that stability after a hemiarthroplasty is really not very much of a concern whatsoever. That instability is almost a non-issue. And so we were probably overly concerned, using sutures to fix condyles as opposed to plates and screws and so on. Initially, we would have thought that would have been maybe kind of risky, but it's turned out that that's pretty successful. So a hemi is a good way to go, but I'll share a couple other things about what would be disadvantages. And the main thing I'm concerned about is the design. So if I had to choose a hemi that was available back in the past and I had to do it today, I would use a Sorby, not the one I designed, unless they let me redesign it. And maybe I should show a screen here. The reason has to do with the fact here, this is the article. You're looking at my screen, I think, right?
Yes.
Yeah. So the reason is that when we designed this spool here, we very intentionally we stopped it right here and did not have it continue over medially the way the normal trochlea does. And there are reasons why we didn't. I don't think you care about those reasons, but we intentionally did that. That turns out to have been not a good idea, because this is what causes the osteophyte to develop over here. There's kind of a stress concentration right here, and so it erodes into the medial coronoid over time. Now, having said that, it doesn't seem to be causing great clinical problems in the experience of those overseas and in Canada who have been doing them, so maybe it's not too much of an issue. But all that put together, I would say that there are some real advantages, and yet it's not perfect either. So I wish we had it available. I did use it for things like severe osteonecrosis and so on as well, steroid-induced osteonecrosis.
Fantastic. Dr. Moore, anything you want to add before we wrap up?
I don't think so. I echo everybody else's. I wish we had it, because in the situations where you're staring at normal cartilage on the ulna, it's really hard to convince yourself, oh, now I'm going to just ream away all this normal cartilage and put in a total elbow arthroplasty because we don't have a hemi available. I think it's sad, but it's the state of affairs with the FDA.
Amazing. Well, thank you all very much. This was incredible. I personally, and I can probably speak for many listening, learned a ton tonight. Really appreciate you taking your evenings to join us and teach us all about this very complex but very fun operation. Clifton, do you have anything you want to add?
No, this was wonderful, and thank you everyone for your great insights. Like Eric says this every time, but I'm going to re-listen to it and learn some more pearls. So thank you.
Eric and Chris,
Fantastic,
very
guys.
well organized as always. You guys are wonderful.
All right, guys. Peace. See ya.
Ah,
Good to see all you guys. Take
thank
care.
you. Great to see you, Matt, too. Yeah.
Bye-bye.
Yeah.
Good to see you.
Take care.
Thank you.
Yep.
Okay. Bye-bye now.
Oh, bye-bye.
Fantastic, awesome.
That was good.
Steve, thank you. That went beautifully. And the video played, and I didn't realize you could share screens, but it sounds like you could share screens.
Your look was the same as are the people still on here?
Steve, have we stopped sharing?
What's going on? I'm sorry.
Is it stop recording or is it still recording?